Antibiotics are substances that kill or inhibit the growth of other microorganisms. In this lecture specifically, we'll talk about beta-lactam antibiotics and study penicillin in detail. Looking at beta-lactam antibiotics, we first need to describe why they are called beta-lactam. They basically have a beta-lactam ring. Now, lactam is basically a cyclic amide. This beta-lactam has a square-shaped structure with a carbonyl group and an amide group. This is called beta-lactam because the nitrogen atom is attached to the beta carbon relative to the carbonyl group. It also has a sulfur group, for example, a thiazolidine ring in penicillins. Now, we don't see a molecule of this shape, the square shape, because it's a very unstable and fragile molecule, and the bonds in this structure are very tense and tend to break very easily. And the bond most prone to breakage is the one between the amide and the carbonyl group, that is the bottom one. Now, beta-lactam antibiotics are penicillins, cephalosporins, carbapenems, and monobactams. We'll only discuss penicillin in this video. Now, looking at the structure of penicillin, I'm going to draw it here. It has the same beta-lactam ring, and it also has a thiazolidine ring, as I mentioned, having a sulfur group and is basically responsible for the hypersensitivity reactions that are associated with penicillins. It also has an R group. This R group can be modified and the natural penicillin can be then converted into semi-synthetic forms, and these R groups can also be modified such that they become protective of the prone bond that is prone to breaking by beta-lactamases or even acid of the stomach. But modifying this R group actually has its consequences. It will actually lead to an increased molecular weight of the penicillin, and thus there will be decreased penetration of the penicillin through the porins into the bacterial cell, and thus a very narrow spectrum antibiotic will be produced. I'll explain that when we are talking about the classification of penicillins. Now, we know that the gram-positive bacteria have a very thick peptidoglycan cell wall, and the porins in this case are attached to membrane lipids, unlike the gram-negative ones, which are present in the outer lipopolysaccharide layer. They have an inner plasma membrane, and in between these two layers we have the periplasmic space. In contrast, in gram-negative bacteria, what happens is that there is an outer lipopolysaccharide layer which has the porins, as I mentioned, and then there is a very, very thin layer of peptidoglycan, about 1 to 2 molecules thick, and between these two layers is the periplasmic space, and then there is the plasma membrane. Now, as we know that penicillins, cephalosporins, etc., they are cell wall synthesis inhibitor, so they are more effective on gram-positive bacteria because they have a significant well-established peptidoglycan layer. So if that synthesis is inhibited, then they will be more affected than the gram-negative ones, which have a very, very thin layer of peptidoglycan. Now, why is a bacterial cell wall so important? What it does is basically it gives support to the bacterial cell, it also protects it, it maintains the shape, and it also allows the bacterial cell to withstand media of low osmotic pressure and thus prevent cell lysis. Coming to the mechanism of action of penicillins, I already said that they are bactericidal, leads to bacterial cell lysis by inhibiting actually the synthesis of cell wall. Now, we know that bacterial cell wall is made up of peptidoglycan, and as it's evident from its name, it has glycan chain cross-linked by peptide chain. Now, the glycan chain actually is composed of alternating amino sugars such as N-acetyl-muramic acid and N-acetyl-glucosamine. To this N-acetyl-muramic acid is attached a pentapeptide which has terminal 4 and 5 D-alanine amino acids. To its third amino acid is attached a pentaglycine chain, and this pentaglycine chain actually needs to bond to the fourth D-alanine amino acid of another N-acetylmuramic acid, while this reaction or this bonding has to occur in the presence of an enzyme known as transpeptidase. In this process, it also cleaves off the terminal 5-D-alanine amino acid. Now, when we said that penicillins were cell wall synthesis inhibitors, we actually meant that penicillins or beta-lactams actually have a structural similarity, or we should say they are structural analogues of D-alanine, and that's why they are able to inhibit the transpeptidase enzyme, inhibit this bonding, and thus diminish cell wall synthesis altogether. Now, one thing to remember is that penicillins or any cell wall inhibitor actually will only work on rapidly dividing bacterial cells, because only these cells will be synthesizing cell walls and provide targets for penicillin and other cell wall synthesis inhibitors. By inhibiting cell wall synthesis, they will actually cause the bacterial cell to lyse and thus have bactericidal action. Now, that's all right about the mechanism of action, but there are many bacteria which have now become resistant to penicillins via three major mechanisms. The first mechanism is via the production of beta-lactamases, that is, they are enzymes that cleave that specific susceptible bond in the beta-lactam ring of beta-lactam antibiotics. This type of resistance is very common in Staphylococci, E. coli, gonococci, that is Neisseria, and H. influenza. The next form of bacterial resistance is by altering their penicillin binding proteins or transpeptidases. This form of resistance is followed by methicillin resistant Staph aureus and also penicillin resistant pneumococci. They do this by altering the penicillin binding proteins, and thus they can evade the penicillins and not let them attach to them. The third mechanism of penicillin resistance is actually a change in the porin structure. So, these bacteria will change the size or the shape of their porins, and thus the penicillin cannot enter the bacterial cell. This type of resistance is mainly followed by Pseudomonas, which is actually an aerobic gram-negative rod. Now, we will see the classification of different penicillins on the basis of spectrum of activity and also sensitivity to beta-lactamases. The first one are the narrow spectrum or the natural penicillins, and they are actually sensitive to beta-lactamases. Next are the very narrow spectrum semi-synthetic penicillins. They are actually beta-lactam resistant because we've changed the R group to be protective of the bond that is prone to beta-lactamases. Next are the broad spectrum penicillins, and they are beta-lactam sensitive. Lastly, we have extended spectrum penicillins, which are also sensitive to beta-lactamases. Now, the first two, the narrow spectrum and the very narrow spectrum antibiotics, are given without any protection to the beta-lactam ring, while the last two are given with protection. Now, what do I mean by protection? By protection, we mean that we administer beta-lactamase inhibitors along with the broad spectrum and the extended spectrum antibiotics to actually save them from beta-lactamases. How do they do that? They actually resemble structurally to beta-lactam molecules, and they are suicide inhibitors of beta-lactamases. That means that they will bind to the beta-lactamases and then be converted into metabolites, and then these metabolites will inhibit the beta-lactamases irreversibly. These beta-lactamase inhibitors include clavulanic acid, sulbactam, tazobactam, etc., and these preparations are actually available in association with the broad spectrum and extended spectrum antibiotics such as augmentin, which is a combination of clavulanic acid and amoxicillin, timentin, which is a combination of clavulanic acid and ticarcillin, sulbacin, which is a combination of sulbactam and ampicillin, and tazobid, which is a combination of tazobactam and piperacillin. Coming back to the classification of penicillins, the first narrow spectrum beta-lactam sensitive antibiotic is penicillin G. It is well distributed all over the body but has poor blood-brain barrier penetration, But in cases of meningitis, when the blood-brain barrier permeability is increased due to inflammation or anything, then it can cross it, and its duration of action is about 4 to 6 hours. Next is procaine penicillin G with a duration of action of 12 to 24 hours. Next is benzathine penicillin G with a duration of action of about 3 to 4 weeks. And lastly, we have penicillin V, also known as phenoxymethylpenicillin. Now, among these, the first three, penicillin G, procaine penicillin G, and benzathine penicillin G, are not effective orally because they are acid labile. That means they are destroyed by the gastric acid. So they can be given IV or IM, but the IM injection is painful. The penicillin V is acid resistant and it can be given orally. Regarding the use of these natural narrow spectrum antibiotics, remember one thing, that one bacteria that is still susceptible to this natural penicillin is Treponema pallidum, the cause of syphilis. Also, Actinomyces israeli, that causes jaw infections, is also susceptible, and we can use a penicillin in depot form, that is the benzathine penicillin, for streptococcal infections as well in some cases, and pneumococci and meningococci are also somehow susceptible. The second class is the very narrow spectrum penicillins, and they include nafcillin, oxacillin, cloxacillin, and methicillin. Now, these are given when there is a known or suspected staphylococcal infection that is not methicillin resistant. Methicillin resistant Staph aureus is responsible for a variety of skin infections such as abscesses, cellulitis, and also pneumonia. Now, one might think that why these penicillins have such a narrow spectrum of activity? Well, they do pay a cost of the beta-lactamase resistance. What happens is that in order to make them beta-lactamase resistant, they put bulky R groups in place of the R group that is naturally present in the penicillin and thus makes it susceptible. But in this case, there is a large R group that saves the prone bond from degrading, but actually makes the molecule very large in size, and thus there is less penetration through the porins of the bacteria, and thus lesser activity and lesser spectrum. Next are the broad spectrum beta-lactam sensitive penicillins, and they include aminopenicillins, that is amoxicillin and ampicillin. Now, both of them have some differences. Amoxicillin has a very good absorption from the gut, while ampicillin is not that readily absorbed, so it reaches high concentration in the gut. And this is actually useful for ampicillin in the cases that it can be used to treat the dysentery associated with Shigella. Amoxicillin will cause decreased side effects because it is in lower concentration in the gut, and thus it will not harm the natural flora as much as ampicillin will do and cause increased diarrhea in cases of ampicillin therapy. Amoxicillin has no food interaction, while ampicillin has a food interaction. Amoxicillin, being a broad-spectrum beta-lactam antibiotic, finds its uses in both penicillin-sensitive and penicillin-resistant cases of Streptococcus pneumoniae, and also it is effective in many gram-negative bacterial infections such as that of E. coli, Proteus, Salmonella, H. pylori, and H. influenza as well. For ampicillin, if you don't remember anything, just remember Listeria. Along with Listeria, ampicillin can also be used in treatment of the dysentery that is associated with shigellosis. The last of the penicillins are the extended spectrum penicillins that include carboxypenicillins and uridopenicillins. They're also known as anti-pseudomonal penicillins because Pseudomonas aeruginosa, that is the cause of different infections in hospitalized patients and burns patients, remember? This organism is specifically very susceptible to these antibiotics. They include ticarcillin, piperacillin, carbenicillin, and meslocillin. Their use will, of course, include Pseudomonas aeruginosa infections and also Proteus and Enterobacteriaceae family. They will chiefly treat the UTIs in the burn patients and hospitalized patients, and also hospital-acquired pneumonia by these agents. Now that we are done with the classification, let's discuss some pharmacokinetics of penicillins. Most of them are secreted via the kidney in the urine, while some of them, two of them, that is naphthalin and oxacillin, are secreted by the liver in the bile. So, most of them are contraindicated in renal failure patients, and naphthalin and oxacillin are contraindicated in hepatic failure patients. Also, another point to remember is that probenecid actually competes with penicillin for tubular secretion, that is, excretion by the kidney. So, probenecid wins and it is excreted in the urine while penicillin is left in the blood, and thus penicillin has higher plasma half-life and thus increased antibacterial action. Coming to the side effects of penicillins, we know that the thiazolidine ring of penicillin has a sulfur group in it, right? So anywhere where there is sulfur, it causes hypersensitivity reactions in the body. Another way of thinking about this is by remembering the fact that we do extract these penicillins from fungus. So we should be thankful that we are not having an antigenic response and just having a hypersensitivity reaction. Well, we should not take the hypersensitivity reaction so lightly as well, because it can lead to anaphylactoid reaction and even shock and death. So before injecting penicillin for therapy, we first need to do a sensitivity test by injecting penicillin intradermally, and if there is a reaction, we should stop and not proceed to penicillin therapy. The hypersensitivity reactions are more common with the naturally occurring penicillins, such as penicillin G. Another problem with penicillins is the cross-allergenicity. That means that if a patient is allergic to one form of penicillin, then there is a very high chance of him or her being allergic to other forms of penicillin. Another side effect is the GI distress that we discussed previously due to inhibition of normal flora of the gut. Lastly, Jarisch-Herxheimer reaction is yet another complication of penicillin therapy in syphilis treatment cases. Now, when penicillin therapy is started in syphilis, the bacteria starts to die, and then when it starts to die, it releases endotoxins that are actually integral parts of the lipopolysaccharide membrane of the gram-negative bacteria, right? So when they are released, then they will cause acute exacerbation of the signs and symptoms of syphilis, that is fever, chills, myalgia, hypertension, etc. And this in the past, this was used as a marker to know that yes, my therapy is working, but now it is simply treated as a side effect and treated with aspirin and corticosteroids.